This is Amy Gibson with the Patient-Centered Primary Care Collaborative. You've dialed into and linked to our afternoon webinar entitled Systematic Leadership Tools to Meet the Adaptive Challenges of Medical Home Transformation. Thanks again for all of you who are participating today. If you have colleagues who are not able to participate on this live webinar, this will be archived and you'll be able to access it up on our website as early as late this afternoon or early tomorrow morning. So we'd encourage you to share this information. This is going to be a great presentation, I have no doubt, so you'll want to share it widely with other members and partners that you're working with out in the community. I want to remind everyone, if you haven't already seen the information about our upcoming stakeholders conference, registration is still open, and now is the perfect time to register because at the end of this week, registration fees are going to go up by $100. So if you haven't already registered for the stakeholders conference, I would encourage you to do that today if you can. The Stakeholders Conference is going to be our first two-day conference, and it's going to be held in Washington, D.C., out by the National Zoo at the Marriott Boardman Park. Again, this is a great opportunity to meet with your colleagues around the country who are working on medical home transformation, many colleagues similar to those who are going to be presenting on today's webinar. So if you're working on medical home in your community, you are interested in engaging other leaders within your organization, please do bring them to our conference. It's a great event and, again, an opportunity to not only hear about some of the best practices that are going on around the country in medical home transformation, but also an opportunity to interface with many of the policymakers and leaders in healthcare that are really trying to make sure that we have full implementation of medical home around the country. So welcome again to our speakers for today. I'm going to give some brief introductions, and then they'll be giving their presentation, and we'll have about 20 minutes of time for questions and answers. The way we do the Q&A on our webinars is if you go and you type in the question text box that you'll see on the control panel on your screen, type in those questions, and what I'll be doing is reading off those questions at the end of the presentation and allow for our presenters to answer those. If we do run out of time, I think our speakers have agreed to stay on for a few minutes after the top of the hour. We do know that many of you have really tight schedules and you're not able to do that, which is fine. If there are a lot of questions that we're not able to get to, we'll post answers to those questions up on our website. So without any further ado, I'm going to go ahead and introduce our speakers and turn it over to them. I want to introduce Dr. Mac Baird, who is professor and head of the Department of Family Medicine and Community Health at the University of Minnesota Medical School. Dr. Baird is head of the University of Minnesota Department of Family Medicine and Community Health and began his medical career in 1978 as a rural physician and has since held academic positions in Oklahoma, New York, and Rochester, Minnesota. His leadership involvement includes service on the Robert Wood Johnson Depression and Primary Care National Advisory Council and co-chair of the IOM Report on Health and Behavior. Dr. Baird recently worked with a multidisciplinary team to develop the Minnesota Complexity Assessment Method, helping to identify barriers impeding patient care and understand social determinants of health. He currently chairs the UCare Board of Directors. Our second presenter today is Dr. C.J. Peek, Associate Professor in Department of Family Medicine and Community Health at the University of Minnesota. Dr. Peek joined the department faculty in 2008 as a consulting psychologist. He specializes in leadership development, organizational effectiveness, interprofessional communication, clinical platform development, and integration of medical and mental health care. Dr. Peek belongs to the American Psychological Association, Collaborative Family Healthcare Association, and Society for Descriptive Psychology. And last but not least, and maybe not last in the lineup on today's list of presenters, but Ralph Jacobson, who's with the Leaders Toolbox. And certainly Ralph is going to talk to you during his presentation about the Leadership Toolbox and how they've been working at the University of Minnesota to help the clinicians there acquire the skills that they need to really lead all of this transformation in patient-centered medical homes. So with that, I'm going to turn it over to all of you and take it away.
Thank you, Amy. This is Mac Baird, and I'm pleased to be on this webinar, and we're going to share our journey on learning a systematic approach to leadership development and why we think it's been helpful for us and perhaps for others. So I'll just go through a brief little summary of some history we've had, and then we'll go right into the leadership tools and the process in which we've been involved. So the Department of Family Medicine is a department with about 94 faculty. We have 8 residencies with which we're affiliated. We run 4 of them as full scope practices, and that's the basis on which we knew we needed to change into the healthcare home. We are going to go through the learning we've had, and as you see in the first image, when we go to primary care medical home in Minnesota, we sometimes call it a healthcare home. We have the obvious attributes of what's needed for population-based but patient-centered care, teamwork, et cetera, that you see on the slide. Now, by the time we got to this point, we had been having some developmental history of our own preceding this leadership need that we saw as a gaping hole in our development. So we had come through a lean process just recently for several years, trying to get out of our own way, more or less, of being clumsy in the care of mostly underserved populations in the midst of residency and faculty practices, of which we have 4 with about 150,000 visits per year combined. Prior to that, we went through leading a culture of quality effort. We went through that with the Institute for Clinical Systems Improvement, or ICSI, here in Minnesota, where we learned that even our own assumptions were limiting our development of quality initiatives. And then prior to that, we've spent several years learning some fundamentals, basics of leadership roles, structure that's designed for action, dyads, and trying to clean up our meetings that we called meeting hygiene with some help from CJP. And then our first effort was really trying to have a basic vision, mission, and goals strategy. That was where we started. We thought we were making progress in all those things at each of these stages, and at every stage we learned we had more to do, of course. So now we're moving into the need for leadership. As we were stuck right about there, we learned that our environment was shifting fast around us. If you look at this S-curve, it's one of the first tools that Ralph Jacobson helped us understand. Our experience on the blue part of that curve was accelerating improvements mostly through lean in those early stages. And then we started slowing down our ability to see objective outcome improvements in the 1% to 2% range. And we were wearing out partially because we hadn't, we feel, developed our leadership skills. And as we saw the yellow curve coming at us, it struck us hard that we weren't built for healthcare homes and population-based, patient-centered healthcare that's team-delivered and team-based. We were in that zone of discomfort for certain. And when Ralph showed us that, we said, oh my, how did you know?
So what we found, of course, is this is CJP now. Our development up to that point of inflection was necessary and excellent, but it didn't prepare us for the challenges of the medical home on the other side. And so you know all those adaptive challenges about, actually having actual teamwork, delegating work, working up to your license, involving patients differently, being truly patient-centered, and caring for individuals and populations, and working between evolving business models, and the list goes on. And what we realized is we didn't really have an algorithm or a systematic approach to deal with adaptive challenges like a piece of work that you can just map out. And so the challenge was to move from a set of different concepts of leadership among our 43 people. Now, everybody had their own book, so you couldn't really communicate back and forth too well. So they had to move it to a common language. And then everybody had their own favorite leader tools. Let's try this way and this process and this graph and this chart. We needed a common leader toolbox. And then we needed similar goals, a set of common leadership goals instead of everybody having sort of compatible but not quite gelling goals. The most important maybe was the old part was having a fuzzy notion of how to tackle adaptive change, where we needed a clearly defined algorithm where there's a map. You say, this becomes normal work. Like, as clinicians, we have algorithms for stuff, even really hard stuff. The question is, how do we get algorithms for doing adaptive change, which can take it from being a political or sort of random process to a rational, deliberate process. So really the structure, the project that we're talking about today is a structured path from the left column to the right column.
So as we looked at this, we learned a lot through lean, but it was actually easier to create standard work for some routinized tasks. It was more difficult at the delivery end, where clinicians deliver patient services and teachers help support residents and students as they're going through their journey. So we learned that we had to have a more distributed competence and lots of leadership issues to move into the next level. We felt like we needed to focus more on action, and we didn't want to talk as much about how do we find the best leader with best personality style, etc. We needed to learn skills so that most of us, in fact all of us eventually, could be a leader in our own role. We needed a platform, not just an idea. We needed an honest-to-goodness platform that wouldn't be a fad of the month. That's where we had a hodgepodge of different leadership ideas, and we'd all read different books, but we needed something we could stand on that was solid. And then we needed to develop a common set of language and tools so that we used a word that meant the same thing across our different sites. When we'd had some of that commonality in the past, we learned that we hadn't reinforced it. We hadn't continued the culture of learning. So that's where we had to have staying power now. If we made something happen, we developed leaders, we had to develop a systematic way to make sure it was reinforced in a regular cycle. And then we had to incorporate our previous learning, so we weren't going to throw away lean or all the mission vision work we had done or all the cultural quality. We wanted to build on that. This wasn't an add-on, it was emphasizing what we'd already been learning and building upon it, not just adding to it.
Yeah, and I want to add two things to what Max just said. Number 2 up on the slide is a cohort model. All of us together, not individuals going off to separate classes or teams doing leadership development independently on their own CMEs. This had to be all of us together moving forward to sort of move the distribution up of the whole group, kind of like the population health version of leadership development here. And the other thing is that from the get-go, the requirement for the model had to be that the clinician and administrator partners were in it from the get-go. Every doctor had their administrative leader, so a clinic program director and a clinic manager. These pairs had to come together. It wasn't just for doctors. So,
and at number 7, when we talk about adaptive change, that's the fundamental change it has to take to go into the new world. We were just getting good at the metrics and the outcomes for fee-for-service practice at the time the world was changing to the other, to population-based health. And if we didn't have adaptive change skills and capacity, we weren't going to make the transition.
That's right. So Ralph's going to talk about the principles of the toolbox.
Well, about 15 years ago, I woke up one morning with a stomach ache, realizing that after having been a psychologist, a human resources guy, and a change agent guy, that most of the stuff that we commonly do around leadership development just wasn't working. And so I realized that I had to sort of look at this and started with a blank sheet of paper and developed some principles that are contrary to what we normally think about leadership development. Because I realized that there were lots of folks that had great passion who wanted to get something done, and when they tried to go and just go to try to implement things, they found that they were really frustrated because things weren't moving fast enough or in the direction that they wanted. So the principles of the leader's toolbox are, first of all, that we focus on leadership and not leaders. In other words, we're not looking at developing the talent of individual people or individuals, trying to assess what their strengths and weaknesses are, because that's very slow, it's very expensive, and oftentimes doesn't get us what we really need. Instead, we focus on leadership, that is, building an organization-wide set of people who can come in and can address the challenges before us, regardless of their rank. So we can work with almost anyone and teach them how to do what we call the leadership kind of work. And the second notion is that leadership is nothing mysterious. It's actually, we can measure leadership, and we can actually pinpoint the strengths and weaknesses of leaders by looking at what they deliver. We have specific kind of deliverables for this leadership role. And we also want, the leader's job is to make sure that there's competence to do the work, and then the third, that they're actually moving the organization forward. Probably one of the biggest discoveries, at least for me, when I came across this concept, was that leadership is a repeatable, measurable, describable process. It's not mysterious. There are specific steps in the process, and when you follow the steps, much like just like a best practice or a pathway, we understand the specific steps, and when people follow the same process, they're much more likely to get the results they're looking for.
So in that regard, we had learned the concept of creating standard work for something that we're about to do, and we're trying to create standard work for leadership. is not just a role that has a seat and that you sit there. There's standard work and tasks and activities you'd be expected to do if you're in a leadership role from the front desk onto the top of the department.
Right. So this helps us understand what that is and provides the same common language from the front desk on up to help us understand what we're supposed to do. Next is the notion that in order to be able to do leadership work, we need new language and tools. And we'll talk about some of the tools here in a few minutes. But we need new language and tools, and we need to have practice. So we create practice fields where people are actually working on the things that are important to the organization, so that they leave the immediate didactic kind of training and they immediately go off to work on the things that have stumped them for such a long time, and they begin to understand that there are ways forward that will get us to where we need to go. So we typically work on adaptive change, again, those difficult things. And in order to help people move forward, what we do is we provide internal and external coaches. So I was the external coach to these teams who actually were assigned to work on some of these difficult challenges. But I didn't do that coaching alone. CJ was with me the whole time. And he and I worked together so that we could provide the best of what was going on in the outside and the inside. And then at the end, we hold people accountable. We expect them to deliver their results to senior leadership. And so at the end of their team experience, they are expected to set a set of recommendations for us to move forward, to which we would then actually implement their recommendations. So our intent is to create a leadership network, a group of people that share common language, common deliverables, common process in order to get the work done. So what I'd like to do is we'd like to give you a flavor for what some of the tools look like so that you understand a little bit about how they work and how they might be different from things that you may have seen elsewhere. The first one we call the 3 roles leaders play. And essentially this tool is not designed to help you become more productive. We feel that you, by this point in your career, that you probably know how to be productive and how to use your time effectively. Rather, this says that there are how you think about what impact you want to have is really important. And we find that most people end up spending most of their time on things that are not that they're comfortable with or that appear to them to just show up in their work. But that's not the real leader work that has to get done. So it's not the most important work. So what we do is we help people understand that there are these 3 kinds of work, leader, manager, and individual contributor work, and that we, in fact, have some control and have to exert some control in order to have an impact on the organization. So Matt, could you talk a little bit about what impact you saw that this tool had on the...
Well, it started very early. So again, in learning about this, the first task was to set aside 3 days for 12 of our key people offline, off-cycle, in the middle of a busy year to actually learn these skills. And I had to use most of my political capital and persuasive moral bank account to get people offline. And we had never done anything in this depth before. We had training for lean in blocks of 4 to 6 hours several times, but we really had to get outside of our normal behavior pattern to learn this in depth. And actually the net result was, in the end, now that we've done several cycles of this, not one person involved has ever said, we shouldn't have done that. Everyone's been very happy. Secondly, when we looked at my own behavior on these 3 tasks that every leader plays, I'm pretty happy to check things off, especially as a physician. I like getting tasks done. I check them off on the electronic chart. I check them off my desk. I respond to emails. I do a lot of that. And it can eat up the entire day, so that if I'm lucky, I do some management things. And on extraordinary circumstances, on extraordinary days, I might do some leadership things, which we'll talk about, setting direction, et cetera. And as we dialed it back and looked at all of our time, we realized we had to create time out of a 24-hour day by managing more in a disciplined way each of these roles. And that's what we're into doing now. We have to hold each other accountable for it, and we don't allow the complaint, I don't have time. If we didn't have time, was it because we didn't set the priorities? We didn't manage our own self-regulating behavior enough to deal with tasks we could delegate or do in a very quick fashion and not wallow in those tasks to shut down the time we had for leadership.
Well, that was the first shock, isn't it?
Yeah.
So 43 people. geez, I don't spend enough time on leadership as I'm going to have to do if I'm going to crack those adaptive challenges in my clinic. Right.
Well, there's actually one more thing. There was actually one more thing that was really cool. Right in the middle of the training, the folks stopped and unscripted, and all of a sudden, folks turned to Mac and they said, "Listen, we at the clinic level, we are going to take more of the responsibility for doing the managing kind of work. We want you, Mac, to focus more on the strategic stuff. We want you to coach us more because we want to profit from your experience. So we're going to take more time and do the stuff that we have normally gone to you, and we're going to do that."
And so they wanted me to be the leader that I'm supposed to be, and not as much of a fixer of their individual problems at various levels. And they were only too happy to then say, "I have enough time. By golly, I've just made it in the model that we're working on, and then you don't have to come in and fix things."
So now the real tool, sort of the map here.
Okay, so what happens is that we normally think that leadership stuff has to be really hard, and we think that it's hard to describe and teach somebody, and there's all this discussion about whether leadership is charisma or whether you're born with it and all of that. And I'm here to tell you that I believe that what you have in front of you is the leader's map, and the 5 stops on the map are probably less important, and we're not going to go through those today. But the piece that I'd like to share with you is that, in fact, after working with a number of CEOs and interviewing them, what I found was that leadership is actually a process, and those people, when they're successful, actually follow this process. And so all I've done is actually pull it together so that it now becomes that which is sort of inside people has now become obvious. And we've created some new language that helps people understand sort of where they are in the change process, what they're designed, what it is that they need to do. So this particular tool helps people plan for and helps people understand what the challenges are that they're going to experience before they even start, and develop a plan and what we call a story around how they're going to address those challenges around the box. And it also says that there's a time and place in which to do this work.
So, for example, we had some prior experience actually with Ralph on balancing paradoxes, which we'll discuss. But it was an early tool, one that we could identify balancing a both-and agenda, but we didn't know how to move past that. So now that we're moving forward, we have a number of insights from which we can land, because we have an algorithm, as CJ says. We have a pattern behavior instead of just making it up from scratch at every turn. So one of the tools we use is a relationship map that's outlined here. And Ralph, you might talk about various parts of it, and I'll fill in some details here.
Well, all of us, the basic part of the map is that there's an us part, which is, in this case, it's the department chair, the administrator, but we're not alone. We have a number of stakeholders that are around us. And our success depends on our ability to manage those stakeholders. And so this exercise is designed, first of all, to help us understand who are our stakeholders and what is it that we give and what is it that we get from each of these stakeholders. And we can actually put some measures to figure out how effective that is. We can decide which of these critical stakeholders are more important to us. And the other thing that's really interesting is we can take this stakeholder map and do it twice. One is an as-is map, the way it is today, and then we can develop the map the way we would like it to be, and that tells us the kind of behaviors and things that we need to focus on in order to create the future that we want to create.
So when I learned about this, I knew that our days in the leadership team, not just mine, but lots of layers of leadership were very busy, partly because of, as you can see, the various colored organizations. But when I put it in this format, we had, just to begin with, we had 16 internal sort of stakeholders within the department. We had 8 of them between the department and the University of Minnesota. And we had, just beginning to list them, we had 18 external to both the department and the University of Minnesota. And in the role of a department head or a leader that I'm in, I could actually name people and themes in each one of those boxes. And unless I was careful, the prioritization was pretty haphazard. And now that I listed it, I would understand a couple things. One, no wonder it feels complicated. It is. It's very complex. And secondly, if I had to prioritize, I might then identify not just by luck who was in each one of those relationships with a give and a get, but who would be best able to interact in a productive way with each of our internal, external relationships, and which key stakeholders will we prioritize. Rather than just off the top of my head, we could now discuss it. And we had a way to deal with it that wasn't just one-off in every instance. And I found that free.
Yeah, the central leader group at the work these was breathed a sigh of relief, having labored to specify it. They said, now I understand the feeling of being extended and all the things I'm trying to balance. So.
And then when we talked explicitly about the gives and the gets, what do I give to some organization or do we give, and what do we get back, we can start to be explicit about what are our assumptions. And by golly, when we go check out our key relationship group, they might have a different set of assumptions. And we learned that we were guessing incorrectly a certain percent of the time. We can now be more purposeful and thoughtful about what we're giving and getting. Trading back and forth is not just money and other resources. For example, now that we're doing this, one of the things we give back, we share with our sponsoring hospitals for our 8 residencies, is leadership. We're giving them talent that they have now in their midst that simply wasn't there before. That's a new asset, a new value we're helping deliver to our collaborative organizations.
So here's another tool.
Yeah, so this is a central business question, and the group absolutely loved this question, and we'll probably, when we talk about how the teams digest it, this was very, very important tool for them. The notion of this tool, this is based on the work of S.I. Kawa, and it basically says that you can look at an issue from a number of different perspectives. So those people that are familiar with adaptive change, this is the way that this is the ladder actually that you can step up to the balcony. And essentially it says you can look at things from a task level, a process level. You can look at the whole practice of the organization, look at things from the industry and humanity. And essentially what we do is we ask the group to develop a question at each of these levels. And then they can determine which level is the most important to them, or what's the most important question that they need to ask right now. The value of this tool is that most people respond immediately to the challenges in front of them, and are likely to look at things from the task level, which if you just look at them will not get us to where we need to be. So if you want to go to healthcare home and you just focus on tasks, chances are you're not going to get there.
I'll give you one example. One of the clinics was looking at part of healthcare home to really reach out and engage, especially their immigrant populations. And their central business question started out as, how do we establish email visits so they don't have to take the bus and come in, and it's really hard for them to do that. Well, they did a little checking, and they got, I think they sent 40 or 50 surveys, and they got like 0 that were interested in it. So then they realized that that was a task-level question. The real question had to go up a notch or two to how do we engage our immigrant populations in ways that they would find truly helpful. Now, as soon as they hit that level of question, it gelled, and they felt this is a good, this question sings, because now we can go find out who are our populations, what are their leaders, how can we find out, and how can we partner with them, rather than just say, we think email will be good for you.
So the value of this tool, and what we found out was important, was the kinds of questions that you ask yourself before you begin a process is absolutely critical. So this makes sure that you get to the right question. So I think we should move on to the next tool, which is the whole notion of paradox. And the notion of paradox is that we distinguish between a problem to be solved and a paradox to be balanced. And most of the issues in healthcare, the ones that we struggle with, the ones that reach the policy levels where Congress seems to be fighting, and many of the issues that practicing physicians and administrators experience every day will never go away. And the reason they won't go away is because they're paradoxes. So in this program, we actually focus on what are the steps that you can take to actually balance paradox, how you tell the difference between a paradox and a problem. And we also learn that tension is not a bad thing. We learned that actually where there's tension, there is the possibility for action, but the key is how we are going to manage those tensions.
So, for example, I think it was around here that Ralph said, when you hear a yes, but, that's an opportunity to learn. So when I would get some pushback on what I thought was a really bright idea, and I would sort of be trying to be too commanding and insisting, once we learned it's a both and, I would learn the other part of this that I hadn't thought of, and we're trying to consider the both and approaches to things. And it gave us a way to avoid having conflict that didn't yield anything. There's so many things we're swimming in paradoxes.
So here's some examples of these situations, these polarities that could easily polarize people too, where they're really, the tension raises and they're at each other and there's a sense of either or. So here, the first clump there, 1 to 3, are the kinds of things encountered in the medical home. For us, it's care. How do you balance care, education, and research instead of which one are we doing? How do you balance patient-centered and evidence-based? How do you balance the care of individuals and the health of populations? And those of you in it know what I mean by these can go back and forth. You can get arguments about which is most important when you really need both. The second clump is really more organizational ones. How do we balance acting locally as separate programs and acting collectively as a department? How do we balance having fidelity to a care model we agree on in our department versus locally adapting it to local conditions? How do we balance standardization and experimentation? We're not going to have people argue for one or the other. How do you work under fee-for-service at the same time there's emerging new business models? So this is just some example. We no longer ask a question of who's right or who is, which one of these is best, and stay in the conversation until it's resolved. The paradox tool gives us a specific method. You can do 45 minutes in a meeting or something to balance and map and balance these. So there's an algorithm. When you hit one of these, you can do something with it.
Yeah, and so what happens is the political heat goes down. You know, the political heat goes down, the silos go down, find that people become much more rational and can focus much more holistically on the issue and develop possibilities that they couldn't before.
Yeah. Okay, so we're going to switch now a little bit to sort of what did we do as a group and what are the results. The first stage was a design team that had Mac and a few of us centrally and Ralph to basically figure out from this, now that we're going to do this leadership development process and we have Ralph in the picture, what are the outcomes we need from this process? What is going to be the process we use to get them, what participants, the names, who's going to be involved, how many, who are they, which tools of the Ralph toolbox, the leader's toolbox, which are the ones that are really going to be important for this particular group? And what are the sort of near-term targets to apply them to? And how the heck are we going to engage all these people to come offline and do this? And say, what are you doing? And say, okay, now I see what you're doing. Then there was a stage of phase 1, we called it, where you train the trainers. You took 12 of these 43 people, and with their administrative partners, and you trained them for 3 days. So Ralph did the training, and then gave them a task. Okay, how are you going to create strong leadership teams?
Yeah, one of the things that we discovered was actually before we began this process, we did some organizational assessments, and what we discovered was that no matter what we imagine for a moment that you have your hands are open and you're trying to collect as much water as you can. Whatever processes or improvements we wanted to make, we couldn't catch them because we didn't have the leadership talent present to be able to implement those things. So what we needed to do was we needed to develop the ability at the clinic level to be able to do significant change work if we were going to be hopeful of creating this medical home. So that's where the derivation for this particular issue was. We realized this was central to our long-term success.
Yeah. And then the next stage was to convene all 43 people for 3 days to train and on the tools and have these interactions, and then divide them up into clinic teams for each of the clinics, and ask them, how are you going to create advanced primary care or medical home at your clinic? In other words, now we're working on the work. And they got to choose which corner of the elephant to work on at first. They had to apply the tools, and then they all knew that they were going to present everything to each other on actually tomorrow.
That's right.
And then the central leadership team got in a place where it needed to say, how are we going to support the clinics and manage our external relationships? So that group fashion there too. So let's talk about the first. There it is. Sorry.
Okay, so the train-the-trainer group. So what we did was after the sort of the 3 days of training, they weren't contiguous, by the way. They were broken, separated out. But after the formal training piece, what we did is we put people into groups of 5, and we gave them a challenge. And in this case, the challenge was, how do we build stronger leadership teams? And then what we did is we asked them and told them that they would have to use the tools to be able to address their issues, and that we provided them, again, CJ and I, this is Ralph, CJ and I both provided this coaching support. So we had 3 or 4 coaching, 1-hour coaching sessions with each of the teams to make sure that they are working on the right thing at the right time, and that they were progressing. And then they presented their results to the senior leadership group.
And during this time, I was already seeing a different type of question being brought to me as a department head. So they would be asking questions mostly about how to balance a local paradox, or how it fit into the larger scheme of things, not a task-oriented thing, can I do A, B, or C? So they were already at an elevated level of thinking, which put me in a better role to help them balance the local agendas with central input.
One of the things that I think is that came out of this that's probably most critical is that the clinic teams began to realize that their job was not just to manage operational performance. They began to realize that they had a number of external stakeholders that that were critical to their success, and that if we needed to get where we wanted to go, that we would have to do it.
So then, as we switched out of that earlier phase into each of the clinics, dividing up and taking on a chunk of the medical home as an adaptive challenge. These are the central business questions that emerged from them. The question they each decided they have to answer in order to move forward with the medical home idea. How do we define the team-based care and build it here? How to successfully join a local gain-sharing type network? How to engage with immigrant communities to best serve their health and wellness? How to implement a team-based clinic structure that's more robust? How to strengthen educational programs in a financially viable way, knowing that this is an academic medical center. So we have to teach new doctors how to function in this too. So that becomes part of the thing. It's interesting because none of these questions started this way. They each thrashed around and used the ladder tool to come up with what is the right level, which is the question, to where they got to where it sings. And that this means something to us. It aligns with the department vision about the medical home, and we can move forward.
One thing about this is that once people found a central business question that they could resonate with, there were no longer questions about when we're going to do it. They found the time. They said, this is important to do. I'll find a way to get it done.
That's right. So in the meantime, the central leaders were.
So as the local leadership improved over the past 18 months and a year especially, our central leadership team had different roles. I mean, we had to be better at leadership, but less at management and less at problem fixing. And so we had to look at what was our basic mission here, what is our purpose, how do we present value to these distributed programs. And we decided that we needed to grow our academic mission to help deliver it, help them facilitate its existence in the local environment and in the emerging models of family medicine. So my job description as a department head changed, and our internal central team changed so that we became a different level of functioning for our local sites. And we had to harness all their energy, and then we had to change along with them.
Yeah. So basically the 14 leaders here that represent peer education and research, and we had a very tightly facilitated process with a set number of meetings and a chart that says, okay, you need a job description for this group. You need updated mission, vision, and goals. You need to compose the process for how that team is going to work and how to sustain the leadership competency. So that group did its own thing, and the central business question then became, how do we balance and grow our academic missions while we move to emerging models of family medicine primary care? So everybody, and then the minute that's in place, it isn't a question of when either. And so that's sort of where is. Now we're going to move us toward wrapping up with the kind of differences that this has made.
So what we found is that we did this at about the time we needed to adapt more dramatically to move into the healthcare home. We couldn't do it with task orientation. Our requirements were clear locally and centrally about what our roles were in leadership and implementation. I had to demonstrate, and our department central administration had to demonstrate commitment to this with resources and consultant. We had participated in developing our language and our tools, and now we need to keep it alive. We have experienced this learning journey as a cohort, so we have to make sure that we continue that learning so that this distribution of knowledge and skills for leadership goes everywhere in the department, and that's what the next phase will be, so that we keep on learning by teaching. And we did work that mattered. We believe that this is how we can, in fact we are, certified healthcare homes and making progress in that journey. And we've gone away from this mysterious leadership myth that we're born with it to how do we have an algorithm for demonstrating leadership skills and have outcomes that we can track.
So maybe there's other things you'd like to comment on, please.
Well, the final thing I'll just say is that this has been a very interesting journey. It's gone, in some ways, much better than I anticipated when we first shocked people by saying we're going to spend this much time and energy learning leadership skills. And now our parent and key relationship organizations see us as helping them develop their own leadership skills. So we've become a new type of asset for our programs, and it's not just a small matter of change. It's a large degree of change, not just around healthcare homes, but our own internal functioning. And for example, we've redefined our own mission now to how will this department bring the university to the community through the practice, education, and research of family medicine and primary care. It's more concise and more able to communicate our academic mission as these practices are organizing to compete in the modern world.
Okay, so where do we go next? Okay, first of all, we have to implement all the stuff that we've been trying to do here and create the local leadership coaching support so that they can do it. So that's where I come in and Ralph comes in. And so build the relationship with stakeholders. The other thing, our other horizon is simply to look more closely at what are the defining clauses of the healthcare home. What does it have to do? An example, the operational definition of healthcare home that the University of Minnesota and ICSI put on the website has like defining clauses. But each of those to accomplish them, there are adaptive challenges. So how are we going to use these leadership tools on those adaptive challenges on that topic? That gets more hard-edged all the time. So that's basically where we're going to go from here. And I think it's time for some questions.
And thank you for being patient.
Yeah.
Thank you so much for that presentation. I picked up the handset thinking that would diminish some of the background noise. Hopefully it sounds like it's a little better now. But thanks again so much. You were all crystal clear on the webinar, and so I appreciate so much the time that you took to talk to us about this leadership model that you've implemented. Just to remind everyone again, if you want to ask a question, you can type it into the question box on the control panel. Usually shows up on the upper right-hand side of your screen. You can just type in a question, and I can read off those questions as they come in. But while people are doing that, I was thinking that we might have you talk a little bit about how you really view this work that you're doing within the context of patient care. You gave some examples about how asking the right types of questions better drives at the specific issue that you're trying to get at. The example you used with the immigrant population and whether or not emailing and doing email type visits was the best way to do outreach. But if you could maybe talk and elaborate on some specific examples on how you really see that this process is going to lend itself to impacting the care that's being received by patients in your clinics.
So I can give an example for one of these is where a local practice and educational leader at one of our sites had a faculty member who wanted to develop a certain dimension of care for mothers and infants and was having trouble getting it established after a year of effort. and it's a very dedicated person. It's an important topic, and during the middle of our conversation, that local practice leader put it on the ladder and said, well, this is a task that we need done, and I see that you're organized around that, but how have you engaged other stakeholders? Who is your ally? Who are the other institutional leaders that can come and help you do this? And how does it fit into the higher organizational priorities? And have you linked it with that? And it turns out most of that hadn't been done. And in the past, I might have been asked that question and tried to solve it at my distant level. And here a local leader was already demonstrating that she knew how to put it in the context of the larger issues and engage this faculty member quite quickly in how to potentially engage a larger group and resources to be more successful in this effort.
Yeah, in a way, it's like whatever the people's good ideas are out there, it helps them, the toolbox helps them work up their good ideas. It helps them work it up. Like you work up a complicated patient, you know, you kind of have the algorithm, you know what to ask, you know how to work it up so that when you go to the consultant, you know what you're asking. The local people with great ideas now get to work it up. You need a stakeholder analysis. What are the relationship maps here? Which are the paradoxes, the polarities being encountered? And then they can do this work and feel like I've done a good job setting up my idea, and for the other people then to be able to implement these things better.
That's great. I've got some questions that have come in. So one of the questions was saying early in the presentation, before talking about the 3 roles leaders play, you talked about the role of the internal and external coaching support. They'd like you to explain that a little bit further.
Well, we learned something through our lean implementation when we had an external consultant, that part of the goal of an external consultant is to develop internal resources that can last much longer than the external consulting contract. And so when we started with lean, we learned that. And now in this case, we had CJ here already helping us organize a number of things. But when paired with an external consultant, Ralph, we wanted to make sure that all of us were learning, but in a way that would be longitudinal, well past the contract date of the external consultant. And so that's how we paired both internal and external consultants for that purpose.
So the external, like Ralph, we would go to meetings together, and he would represent things that none of us had thought of because we're on the inside, and had the toolbox all organized, which we didn't have. And then I would know the internal facts of what was going on and some of the inside stories and the language that would fit. And I had relationships with them that would last longer than Ralph's contract. And so then the two of us would work that way. And then many of the things become transferred more internally. And then as an internal consultant, my job will be to help continue to develop the internal abilities for people to do this, including what I do.
So one of the first challenges, Ralph, maybe you could chime in, one of the first challenges that we did here was we didn't have any time for this. How in the world can we plan our local leadership team development when we're busy, 22 hours out of 24? And they would expect our central organization to say, okay, take another X hours a week off of everything else, subtract your billable hours basically, and then you'll have plenty of time to do it. And we said we have to create our own time. We have to organize ourselves among the 3 roles leaders play, and be disciplined about how we spend our current time.
Yeah, so my job as the external coach is to bring in new language, new ways of looking at things, and to stretch people, to have them look at things that they never thought were possible before. Now what we can do is, I have the luxury of being able to be the tough guy sometimes and creating a higher level expectation than they normally would. And also I'm there to say, this is you are using the tools in the right way, or here's some other things that you could think about using. Those are some skills and some talent that may not be internal inside the organization.
Thanks. And I think we hear from a lot of our consultants that work in primary care practices too, that it's just so critical to have someone who can take that external view to really assess what the needs of the individual practice team are, and within the context of their overall organization too. So I think that external point of view really helps in setting some of those priorities and focus areas for the team.
Yeah, the other value, by the way, is of the internal coach is we do not want this to be the flavor of the month. We want this to be sustainable over time, and so you have to build in the capacity for the organization to be able to pass the baton so they're able to do this work by themselves.
That is so true, too. Another question we have, did you have a didactic leadership curriculum, and what did that involve and over what period of time?
Yes, we had, there was a didactic period of leadership, and so what happens is the fundamental framework of the toolbox is that there are 3 days of training, and it revolves around a non-healthcare kind of case. So it's a simulation. It's a simulation of an organization that's in trouble. And over the course of the 3 days, the leaders are exposed to the various kinds of issues that would naturally pop up in any organization that would be problematic. And so I basically teach the tools, we apply the tools over the course of the 3 days. So the folks here in family medicine chose which tools they wanted to have in the box, and then we used this business case.
So there's another piece to that. We had to have a certain amount of preparation even to make the best use of the didactic curriculum that Ralph so nicely brought to us for 3 days. For example, way early we had to say, well, who's on the team? Who are the leaders? Are you all paired up with your administrative leaders? How do you work with an administrative partner, physician-administrator partnerships? How do you have decent meetings? There were some very, very sort of rudimentary leadership training that made people sort of organized enough to benefit from this.
Yeah, there was a little bit of controversy about whether or not we should use a non-healthcare business case. And what we found was that, in fact, it was really helpful because once you use a healthcare-related case, then people are looking for the answers. So in part one, we just want people to learn the material. When they're off on their teams focusing on an issue, we definitely want them to be specific around the issues that they're experiencing.
And part of the reason we use the train-the-trainer model is we were convinced by Ralph that if we didn't teach it, we wouldn't really know it. And so now we're having the second wave, and then the third wave will be those 40 people, 43 people teach others.
So a bunch of those tools were taught in the large group by the first few people that learned.
And I want to say that when one of the first things we saw visually was the S-curve, and it rung true with us that now that we finally figured out how to do better visit-based fee-for-service medicine with lean, why would we change to this new model that isn't here yet? And we had to honor both those that wanted to be staying skilled in the current world, and yet honor those adventurers that helped us move into the new world on the new S-curve. And so that immediately gave Ralph credibility that he seemed to understand what we were up against.
That's great. I think that's a good lead into this next question that just came in. Can you talk a little bit about the type of percent effort required to really develop these leadership skills, and is the buy-in for this program sufficient to be sustained long-term?
Well, this was one of our biggest efforts ever in taking people away from their normal duties, some of which we're paid to do, and put them in a place where we couldn't bill anybody for our time except the department would support it, and spend enough time at it so they would both internalize, they'd learn new things and then internalize it. And we didn't trust that was going to happen in 3 days either unless we were going to teach it to others. And then address real world problems after learning on a sort of a template that was a problem that we didn't normally deal with so we could practice the skill, not just jump to the right answer. Then we had to internalize it, and it's still ongoing. So we're a year into this. We think it's a longitudinal model, and what the evidence we have that it's working is the types of issues that come to me as a department head are now different. They're more how to balance a given paradox, and they're more elevated in their understanding of the larger system issues every time they bring them in, or most of the time. And they're asking me to set the direction, to ensure competency, and to establish accountability rather than solve the problem, and that's helpful.
The other thing I think for the sustainability thing is the gamble, the bet you make is that if you dose it properly, you have to have the right dosing. In other words, that was for the whole 3 days. The major effort is to get enough in the system to make a long-standing change. A lot of leadership things happen on a really tight on the shoestring, so that you have a couple of hours here and there, and then there's not enough dose to make a real difference. Whereas this is important, big enough to do.
So we didn't add any percent administrative time to anybody's schedule. We asked them to look at their administrative time they have now and organize their own effort such that they would have time to do the leadership issues and management issues and not just the task. Most of us were embedded in tasks that we could do in a more efficient manner and or delegate.
There are a couple of things. There's a question about sustainability that's embedded here, and there are a couple of things that I think are really telling. The first is that some of the language is now as if we have done it for the last 5 years. So people talk about what's your CBQ or what's the paradox or what's your IML. So the language is already embedded, and so much so that some people who were not part of the training wonder when they can get it. So they're wondering, so they're seeing this as having added some value, and so they're approaching us and saying, so when is the next round? How can I learn this information and these tools?
And we knew we couldn't take everybody offline all at once, and so the interesting thing that comes to me, instead of why must I learn this interesting issue about leadership, what's happening, that isn't the question. The question comes up, why wasn't I included in the first or second round? When do I get to learn this? When do I get to see the materials? When do I get coaching time? And I've got the time now, I'm going to create it, so when do I get access to this new insight of how we get things done?
Everyone wants to come to the party now.
Yeah, it's more fun that way when they're insisting on it versus me.
Right, right. I'm going to just do one last question, and this is going to kind of build on 3 separate questions that came in. You know, a lot of what we talk about in patient-centered medical home is team-based care, and I think you addressed a lot of this in talking about all the different areas and subspecialty cares, and in terms of how do we work better and how have these leadership skills over time helped the team work better in providing patient care. What kind of changes have you seen over the course of this journey in terms of how multidisciplinary teams are working in a patient-centered medical home?
Well, I'll start, but maybe we'd all 3 have input. It's not magic, but what I do see that's different is more careful listening to the problem being presented as a potential paradox as opposed to a yes or no answer. For example, I see a question listed here about integrating mental health. The question might come, does this person get 4 hours on Thursday or 2 hours on Monday or something technical like that? And the question comes to me now is, how do we embed this so that it's functional? How do we create the proper circumstance for that team member to be properly positioned? And it's more how rather than a what question. And I can offer some insight, but they still understand they're going to solve the problem locally with support from somebody in the central administration.
I would say that, this is Ralph, I would say that one of the things I see is that people have expanded their notion of what they can do and why they're here. And the limiting assumptions about what impact they can have on their organizations or in healthcare or their communities is much greater. And so what I think is we have tapped back into people's passion. I think too often what has happened is that people are focused on accomplishing day-to-day kind of work and feel stressed out by that. And what this work has done is help people connect back into their mission about why they chose healthcare in the first place. And I think we've built an excitement and a capacity for people to work across the silos much more effectively because we're asking the bigger questions that Mac is talking about. And so it now becomes less of what's the solution into let's just think about how we can work together on a bigger issue and so that we can work collaboratively.
So when we come to the healthcare home nitty-gritty, what does the care manager do? Where does he or she sit? How much of the role does that person take on versus a physician or that's tending physician or the resident? Why doesn't the nurse do that, et cetera? Those are conversations that are shared now without assumed correct answers, and they're mostly trying to fit the larger pattern we established, but they want local adaptive solutions to it.
Yeah, this mental health, integration of mental health is a good example. It's a group of clinic medical directors and clinic behavioral medicine people that are jointly led by the behavioral medicine director and the medical director of the whole shebang, working out, creating a template for what does integration of mental health mean in our healthcare home, And then how is that tailored locally? And then what are the workflows? So that group is sitting and cranking out the workflows for it. But part of it was the attitude about leadership, the ability to take the time to do it, and some of the tools made the group sort of know how to act when they got together and start to do the work.
And they're actually seeking these opportunities to implement the dimensions of a healthcare home as an opportunity to demonstrate leadership. So how do they ensure competency to get things done? What is the competency involved in each of these team-based roles? And then how do they seek to be held accountable? Instead of me sort of creating some arbitrary metric for accountability, they want to test these several models for accountability and how could it be sensible from their perspective versus me create something out of the blue and put it on them.
Thank you so much for all that information. I think you brought to the forefront one of the major issues that we hear from across the country that practices are challenged with, and is how to really obtain those leadership skills that are really necessary in making this transformation in primary care, how we deliver care, and again, really redefining those roles within the medical home team. So thank you so much for sharing this model, and we'll look forward to hearing more updates from you and reporting in on how this is continuing to move an advanced patient-centered medical home at the University of Minnesota. Again, for those of you who are still on the line, if you were not able to participate in the entire webinar, or if you have colleagues that would like to hear this information, this webinar will be archived up on our website by tomorrow. So feel free to download it and listen at your leisure. We have several other webinars that are coming up in the next few months, and of course, we try to get this information out to you on these best practices and have timely information to share with you. So if you're not already registered to receive our emails and communications, you can do that through our website as well. So thanks again to all of our presenters and all of you who joined our call today, and we'll be talking with you soon. Thanks again. Bye-bye.
Thank you, Amy.
Thank you.
The organizer has ended the session.